Now it's time for tonight's orthopaedic question time. Please welcome your host, Mr. Jonathan Dimbleby.
This event is the first of its kind, organised by the BMI Bath Clinic and Bath Clinic Orthopaedic Specialists. And it's a question time, and its role is to explore some of the very important orthopaedic questions that are on your minds, people who know about it, have concerns about it, and with a fantastic panel of specialists. Our first question comes from Dr. Jamie Jones. Dr. Jones.
What is the prognosis and possible surgical operations involved in someone who's diagnosed with ankylosing spondylitis at the age of 16?
You know, I think recognizing people under the age of 40 who have this kind of back pain and thinking they may have ankylosing spondylitis is very important. With the juvenile onset patients, they tend to have a worse prognosis, so they are more likely to develop syndesmophytes and spinal fusion, but I really have to say that the number of patients who progress to that level are tiny. I have 715 AS patients on my books at the Min, and 5 people have had surgery.
When is a resurfacing of a hip a better operation than that of a total hip replacement?
Our Sherman have a pair of them he had done in Birmingham, and as you've seen, he's been skipping around happily. So that's not advertisement, but that's only a small statement to people you know, people running in front of you doing very well.
The only downside of them is when you go through airports, you are automatically, you have to say hands up as soon as you go through, and then you try to explain, and if you don't understand their language, they don't understand yours, they look at you with even greater suspicion, and that round thing is until they find it eventually.
Cled is possibly the most senior in the surgeons here. He wouldn't let his patient go back to play tennis or squash. He wouldn't go running marathons, not on a hip replacement, but on a hip resurfacing, yes, you would.
And I have to say that I have had my mobility was impaired, and I play tennis quite ferociously with a coach, and I ride horses, and I have more mobility now. I have to say, maybe I'm one of the lucky ones. Far more mobility. I'm 68 than I had when I was 40, and I did a lot of sport. It's unbelievable. It feels like having 20-year-old hips, and I see friends and colleagues beginning to stiffen up. And I'm sure my back's stiff, but I never have any problem from the hips. Nothing at all. Who's in favour of resurfacing? Hands up. Who prefers replacement? Hands up. Who hasn't got a view? Hands up. You are so cautious, you lot. Jacob Hayes.
My question is, what are the criteria for surgery for Cauda equina syndrome?
Well, I was just going to chip in, really, as I hadn't said anything yet. As I'm rather long in the tooth and have been practicing before the time of MRI, I can only just really say to everybody how wonderful MR is for Cauda equina syndrome.
Good evening. Orthopaedic surgical options seem to have outstripped the available NHS funding, and I think we're seeing that local commissioners are now starting to limit access to certain procedures. I mean, I was wondering whether the panel thought that it was time for a recognition that the NHS just can't provide all of these procedures, and that some sort of national policy should be created.
Steve, you start.
Thank you, Nick. It's a very good question. It's also one that's quite difficult to answer. So, Cled, if you want to chip in at any point. I think we all know that a lot of orthopaedic procedures are amongst the most effective operations that we do in terms of improving people's quality of life. And although the conditions that we see are often not life-threatening, they can make a very big difference to the patient's overall well-being. And at the end of the day, the pot of money that we've got to treat everybody with, whatever's wrong with them, is not infinite. So at some point, I think there will be a need to realise that things have got to change.
Is it justified to spend £10,000 to prolong life by 6 months rather than give 2 or 3 people a hip replacement or better quality of life in a nursing home or a geriatric department in a hospital?
I just thought divert slightly because I involved in the family running of a cancer charity, and one of the things we did was to redecorate the resources that we had, and we set ourselves a budget, which was the NHS budget for a room of that size, which had to have chairs in it and other natural environment, just like a comfortable room. And we did it to that budget. And patients who came in for care of one kind or another, cancer care of one kind or another, absolutely love it, because it feels like a room you want to be in rather than a utilitarian space in which you are simply a number. Raj?
I just think quality of life is such an understated and under-recognised thing. And I'm really keen these days on addressing these issues. So in clinic, I'll talk about people's work and their family life and all the other things that go along with just getting a hip or a new drug started. And, you know, we have to get to that point of where we do those economic analyses of keeping someone at work, making sure they're not taking time off sick. Actually, if you don't replace that knee or do something about the knee, you'll have a problem with the hip, you'll have a problem with the back, you'll have a problem with the other knee, and suddenly you've got 4 other areas to worry about. So I don't think just avoiding one will leave the problem behind.
Yeah, I mean, I agree with most of the things that my colleagues have said. I think I recognize the fact that the NHS has to save some money and in order to survive, but at the same time, I also recognize that it needs to become more efficient and to spend money wisely.
Good evening. Do you feel the decrease in post-operative NHS orthopaedic physiotherapy has influenced outcome post-joint replacement?
But certainly from my experience with patients with rheumatoid arthritis undergoing hip replacement, knee replacements, and from your own experience as well, they do come back to us at the men for some more extensive rehabilitation. The reason we can provide good outcomes and better care is because we work in a multidisciplinary team, and that includes the physiotherapists. Without the physiotherapists, we would not be able to produce the quality of the service that we currently do. And so for us, we would fight any cuts for physiotherapy services for our patients, because I think it's an essential component.
I cannot speak of it highly enough. Without these people working close with my patient, certainly my outcomes, or my problems, if you like now the word is, would be low.
Would it be a priority for you to ensure that the resources for physiotherapy were not being reduced, but were being sustained even if the knock-on effect was somewhere else?
Absolutely. If I have to choose the patient come and see me at 6 weeks or see a physiotherapist, they better off see the physiotherapist rather than me, because I wouldn't do that much good to them as she would.
Good evening. What are the latest advances in minimally invasive surgery and computer-assisted surgery?
So you can, in terms of minimally invasive surgery, do smaller incisions, very little muscle trauma, get them up and walking even on the same day, get them out and going and returning to a high level of activity. So by around 4 weeks, they should be walking without any sticks or any crutches, and even going back to work sometimes. So we're now doing that routinely here in Bath. In terms of computer-assisted surgery, I did quite a lot of work on computer-assisted surgery some years ago. I thought I was going to do a lot more computer-assisted surgery in Bath, but I don't think the results of it justify the usage of it in terms of potentially the outcomes.
On computer assisted, any hospital you visit, NHS hospital here in Bristol, anywhere you go, if you go to the central hub in theatres, there is always a corridor goes aside. Yeah. You will find the machine standing there collecting dust. And if you ask the nurses when was the last time someone used it, said, oh, we had a visitor and we got it out 2 months ago. MIS, however, is different. MIS does offer faster rehabilitation and quicker recovery and less pain. And certainly the scar is there forever. It's a small scar, so particularly women, you can hide it very well around the hip or around the knee. And for some people, that is very important.
Quite important for some men too.
I wonder whether Ashok could explain whether the vitamin D deficiency is a new epidemic or a new fashion, and particularly whether vitamin D should be a prescribed drug or a purchased essential dietary component.
Do I sense that built into that is a point of view as well as a...
Vitamin D is not something you can take through dietary means. We don't fortify foods in this country, so the dietary sources of vitamin D are relatively limited, and most of the vitamin D that you have in your body is cutaneously synthesized, so this means you need to have the right sunlight and the right time of the year. And I tend to encourage patients to buy their own vitamin D because I think it's like a supplement, and they're used to buying supplements. Just for the audience, there is going to be a document produced by the National Osteoporosis Society which will put all this into a better context as to what should be the acceptable levels and how to replace or replenish somebody's vitamin D status. So that document should be out in a couple of months' time.
Palsy. What further diagnostic testing helps with this diagnosis, if any, to distinguish a palsy from other issues with singeing or singeing scapula? Singing scapula?
Winged scapula.
What's it?
Winging.
Winging. I've got an S instead of a... That's a singing scapula, but it does actually sound like... when it does kind of sit... Whoa! I know myself.
I think nerve conduction studies are more helpful than an MRI for that particular condition.
It's a question which I'm asking. What bone condition, surgical procedure, or clinical sign, symptom, or whatever, would the panel individually like to have, I was going to say his or her, his own eponym attached? Raj.
So I'm going to go for the Sengupta sign, which is in some AS patients, I've seen that they have fusion at the top, so between C2 and C4, for example, and then from C5 to C7 down, and so they have a mobile segment. And these patients get a lot more pain than others. So that's going to be the Sengupta sign of the future. Thank you, Jonathan.
Shall we give him that? Okay, you've got it. We won't forget. Ashok.
Well, it's just difficult. I mean, a few years ago, we wrote a paper up of a case of a man with psoriatic arthritis whose x-ray showed as if one of the hand surgeons had done a very neat operation on the metacarpals and taken off the metacarpal heads. But of course, there was no scar. He'd never had any surgery. So we wrote this up as a pseudo-surgical hand. And I wish I'd call that Barla's pseudo-surgical hand.
Avisandu.
Again, it's quite difficult to answer that, but I think one of the things I always tell the registrars is just be sensible, just be sort of rational and just think through things logically, and don't go mad and don't try and do the weird and wonderful like the computer-assisted head replacement or something. So just put sensible Sandu.
Sensible Sandu.
Sophia Harvey.
Cledwin.
Mr. Chairman, I don't need to have my name scattered in the literature anymore. There's a Jones fracture, there's an atypical Jones fracture, there's a Jones procedure, and there's a modified Jones procedure. And
there are lots of Joneses around.
Yes, it wasn't all the same person. Actually, that was the same person. It certainly wasn't me, I have to say. And someone's actually gone and named the protein after me, the Benz-Jones protein.
Excellent.
What else can I say?
So you're secure. Michael.
Well, I'm glad you started at the other end. That gives me a chance to think. Now, if I go for one of these wonderful new operations, the chances are in a few years' time it will go downhill and my name will be Mud. So I'd rather do something that's very rare. And one thing I've only done twice in my life is a total femur replacement. That's when you have a bad hip and a bad knee, the bone is gone, so you put a huge big rod in between. The chances are that can't go wrong and nobody would remember it. And I just slip quietly.
And finally,
total femur.
And finally, Steve Pope.
Well, I don't think there's been many popes doing orthopaedic surgery, but I would say that one thing I do regret is a small thing, but when I was a registrar, I modified some pins that we used during knee replacement surgery, and they were colloquially known as the Pope's pins in every hospital I worked in London. And actually, they're now, I can ask for them in RUH and the Bath Clinic, and they will get them out off the shelf, and that's what they are. But I never made any more of it, and I got the company to modify them, and we all call them the Pope's pins wherever I've worked. But I would like that to have been something that had been more generalised.
Well, I think he deserves that as well, don't you? Thank you on behalf of BMI for coming here. I've enjoyed it. I really enjoyed listening and learning this evening. So thank you to everyone on this panel for that. And thank you for the questions without which this programme could not have taken place. Safe journeys home. Good night.